The following is a reproducible and effective bicep tenodesis method utilizing in-office nanoarthroscopy. Advantages of this technique include the patient's ability to undergo a diagnostic and therapeutic procedure in the office setting and actively participate in the understanding of their condition. Additionally, the minimal invasiveness of the technique allows for less swelling and pain. Potential disadvantages include the inability to convert to an open procedure and the learning curve associated with the wide-awake patient and zero-degree scope. The patient is seated comfortably on the examination table with the back of the bed set to approximately 70 to 80 degrees, and the ipsilateral shoulder is positioned so that the posterior, lateral, and anterior aspects of the shoulder are unobstructed. Using sterile technique, the patient's extremity is prepped and draped. The arm is supported on a padded Mayo stand and slight forward flexion and abduction to allow for optimal entry into the glenohumeral joint. Relevant surface markings include the acromion, clavicle, coracoid, with the posterior, lateral, and anterior portals marked as above. Prior to the procedure, the portal sites are injected with a 1-to-1 mixture of lidocaine with epinephrine and marcaine. A standard posterior arthroscopy portal is made. Using an 11 blade, a 2 mm stab incision is made to accommodate the 1.9 mm 0-degree viewing needle scope. A diagnostic arthroscopy is conducted viewing the labrum, glenoid, humeral head. The long head of the biceps tendon is visualized, followed by the subscapularis, MGHL, and rotator interval. The scope can then travel over the humeral head for a complete look at the glenohumeral joint. Under direct visualization, the anterior superior portal is established by passing a spinal needle just inferior to the biceps tendon in the rotator interval. A small 3 to 4 mm stab incision is made and a nano probe is placed. Attention is then directed to the biceps tendon. Utilizing a 2.75 mm bird's beak suture passer, a 1.3 mm suture tape is passed through the biceps tendon approximately 1 to 1.5 centimeters from the bicep labral anchor. The bird's beak is inserted 5 mm to 1 centimeter from the long head of the biceps origin and the suture tape is passed. The two limbs of the suture tape are tied to the overlying shoulder capsule at the level of the rotator interval with an arthroscopic knot pusher, ensuring adequate cinching of the knot. Excess suture tape is cut using arthroscopic suture scissors. The previous steps can be repeated to ensure stability of the construct. A nanobiter is then utilized to tenotomize the biceps tendon at its labral junction. A 2 mm shaver can be used to shave down any remnant of the remaining biceps at its previous origin. Portals can be sealed primarily using adhesive wound closure strips or with simple nylon sutures at the surgeon's discretion. A dry sterile dressing is applied that facilitates early range of motion. Pros of this technique include proper patient selection and a thorough pre-procedure discussion. Additionally, adequate time between portal placement and intra-articular local analgesic injection. Pitfalls include poor patient selection and poor portal placement given the 0-degree needle scope.